So without wasting any further time, I would like to introduce our first speaker. Just to mention, this webinar section will be in 4 parts, but we have 3 speakers, and one of the speakers is going to be handling 2 parts out of the 4 parts. Each part is going to last for 8 minutes maximum. So introducing our first speaker, who is going to take us on the first part of this session, he's going to be talking about stroke. What is stroke? He's going to talk about the clinical presentations of stroke, and he's going to elaborate on the difference between hemorrhagic and ischemic strokes. So while I go through the profile of our first speaker, I believe the screen is already sharing a screen with his presentation slide. So our first speaker is Professor Benjamin Anyanwu, who is the Executive Director of Regions Healthcare, Hospitals and Specialist Clinic Owerri in Nigeria. He received his residency and fellowship training in the United States and is triple board certified in general neurology, vascular neurology, and neurocritical care by the American Board of Medical Specialties and United Council of Neurological Subspecialties. Professor Anyanwu returned to Nigeria after over 20 years of practice in the United States to establish a multi-specialty hospital, Regions Healthcare Hospitals and Specialist Clinic, that is located in Owerri, Imo State in Nigeria. While in the United States, he was at various times the medical director of Novant Health Comprehensive Stroke Program, also medical director of Neurocritical Intensive Care Unit, and a chairman of neuroscience of Novant Health, Forsyth Medical Center in North Carolina, USA. With his leadership and collaborations, he established a telestroke consultation program here in Nigeria called the Region Stroke Alert, which offers neurological and stroke consultations to hospitals across Nigeria through telemedicine. His commitment to transforming Nigeria's healthcare landscape has been widely recognized. In June 2024, he was honored with a special recognition award by the National Healthcare Excellence Award, NHEA, for excellence in stroke management and neurosciences in Nigeria. Additionally, in a historic recognition of his service to the nation, Dr. Anyanwu was conferred with the Distinguished Service Award by the Nigerian Medical Association, NMA, during the 65th Annual National General Conference and Delegate Meeting, acknowledging his contribution in the health sector and to the Nigerian Medical Association. In July 2025, he was one of the 20 awardees who received the National Diaspora Merit Award by the Nigerians in Diaspora Commission, NITCOM, acknowledging his immense contributions in the medical field. He is an internationally recognized leader in stroke care, a global health expert, a philanthropist, and an accomplished healthcare administrator. It is nice having you here today, Professor Ben. We really appreciate your time. We would also want you to, you already have your presentation shared. You can then go ahead now with your presentation for 8 minutes. Thank you very much.
Thank you very much, Otis. Can everybody hear me? Otis, can you hear me?
Yes, we can hear you loud and clear, sir. Go ahead.
Well, thank you for that introduction. I guess with all of that, I don't need much introduction anymore than to just delving into my slide. Just give me a minute here. All right. So currently, I'm the Executive Medical Director of Regions Healthcare and the Director of Stroke there. And I'm also the Medical Director of that program that he mentioned, Regions Telemedicine, Stroke Alert, that offers stroke service across the country in selected hospitals. So I will start this conversation by starting with what is a stroke. Our assumption for this presentation is that we have a mixed audience. Some are medical, highly trained medical personnel. Some are general audience in the community, and it's important that we match a presentation that can be able to fit this diverse group of individuals who are listening to us today. So in a nutshell, the brain controls every activity in our body. both my ability to see or move my hands or talk. And each part of the brain is supplied by its blood vessels that bring blood and oxygen to that part of the brain. When that blood flow is cut off, either from the blood vessel bleeding or there's a blockage, as you can see in the diagram above, that part of the brain is deprived of oxygen and blood supply. And very soon it dies. And when it dies, you have suffered a stroke because you will lose function of that part of the brain in the body. There are basically two types of strokes. One because of a blood clot we call ischemic stroke. And this is really a blood clot that blocks that blood vessel, therefore restricting or obstructing blood flow to that part of the brain that is concerned. Another type of stroke would be what we call a hemorrhagic stroke, which, as you can imagine, if the blood vessel bursts open, there will be bleeding. And if there's bleeding, there will not be any blood supply to the affected part of the brain. Both hemorrhagic and ischemic stroke make up what we call stroke in general. Stroke is number one cause of disability in adults. And the disability arises because of that lack of function or loss of function of the part of the brain that controls either your walking, ability to see, talk, or move at all. In Nigeria, we estimate that about 200,000 strokes occur every year. We think that that number is much, much higher because a lot of people don't go to the hospital. Most people, as you know, end up in the traditional homes or in their home and don't seek medical care. But what's more alarming is that the case fatality in Nigeria from a stroke is about 28% within the first 7 days and about 40% in the first 30 days. These numbers are very high, meaning the chances of this turning bad if you've had a stroke, it's about these numbers. Having said that, for most of the audience, the news is not so bad, but I think before we talk about what we can do about a stroke, one of the first questions somebody would ask is, how do I recognize a stroke? So the simplest way to recognize a stroke is to master the mnemonic that I put on the board there, which is be fast. When somebody suddenly loses balance, they can no longer walk straight. That's the B. The E in it is loss of vision in one part of the eye that occurs suddenly. The F is a facial droop, one part of the face drooping to one side. A in B fast means arm or leg weakness on one part of the body or sometimes both. S is loss of speech or difficulty in speaking. And T is the time to act. We will talk about our time to act in the next few slides, and my colleagues will take upon that as well. It's important that no matter what you think, like our people say, it's not my portion. It's important for us to recognize in any room or wherever you are that 1 in 4 of us will suffer a stroke in our lifetime. So if you have 4 people in that room now, or wherever you are in your office, just consider that in your lifetime, 1 person in that group will suffer a stroke. If you've suffered a stroke, time is of essence. And therefore, we have a mnemonic as well that we say time is brain, which really refers to the fact that as you have suffered a stroke, if you do nothing about it, the brain continues to damage and that damage continues to get worse. So the picture I have there is a patient who has suffered a stroke in the first 30 minutes. The dark area is the area that is dead. In 2 hours, if you don't do something to get blood flow going in that part of the brain, that stroke will expand. The dark area, as you can see, getting large and larger. By the time you're 12 hours into it, it's even much, much more bigger. The good news, though, is that if you do something and do the right thing, which the next speaker is going to talk about, you can restore blood flow to that part of the brain. And once blood flow is restored, function is restored as well. This is the reason why this year the theme for the stroke, the World Stroke Celebration is that every minute counts. It refers to that ability and that knowledge that you can save the brain if you do the right thing very quickly. Thank you for listening to this first segment of the conversation.
Thank you very, very much, Professor Ben. It's a wonderful presentation, very insightful. We truly appreciate the valuable points you have shared. I'm sure all the audience have learned a lot from your session. I want to encourage everyone present for this webinar. Feel free to go to the chat section, drop your suggestions, drop any question relating to this topic that you want to ask. It's an opportunity. It's a privilege to have three of these great speakers here in one place today. There's an opportunity for you to ask questions and get more insight to any area that you probably need a proper clarification. So the chat box open. You can throw in your questions there, and we are going to look into those questions towards the Q&A session of this webinar. Now we have our second speaker who's going to be talking on the risk factors of stroke. What do strokes and cardiovascular disease have in common? He's also going to talk about the modifiable and non-modifiable risk factors. He's also going to expand on how we can prevent stroke. Without spending more time, I want to introduce our next speaker who will be taking us on the part 2 of this session, Dr. Adeyemi Johnson. A profile of Dr. Adeyemi Johnson. Dr. Adeyemi Johnson is the leading interventional cardiologist and healthcare leader whose work has greatly advanced healthcare in Nigeria and across Africa. He is the founder and medical director of First Cardiology Consultants, Lagos, and also the founder of the Healthy Heart Foundation, which is one of Nigeria's most active heart health charities. He has instructed me not to go through the whole of his portfolio because if I decide to do so, I'm sure in the next 1 hour we'll still be talking here. So we're gonna end the profile of Dr. Johnson at this point, and we're trying. Okay, we have a slide already shared now. Dr. Johnson, 8 minutes. Over to you for your presentation. Thank you very much.
Okay, can you hear me?
Very clearly,
can you
sir.
hear me?
You.
Okay, good. All right. Good afternoon, everybody. Thanks for joining in this session. Now, my part of this is to try and prevent you from getting a stroke so you don't come to the hospital looking for treatment. Now, my experience is this. Since I started working in Nigeria, I can tell you that 80% of the heart attacks and strokes we see at First Cardiology are preventable, 80%. And when I go through the risk factors, you'll understand what I'm talking about. There are risk factors you cannot control, but there are also risk factors that are all within our control. And like I said, 80% are preventable. I would like to start with a little story. It's not on prevention, but the first stroke we took care of using modern techniques, using what we call thrombolytic therapy, which Dr. Ahmed will talk to you about. The first one we had at FCC when we first started. This was a patient, a foreigner from Denmark, I believe. They were in a conference in Otta for Nigerian breweries. Hello. Can you hear me?
We can hear you, sir.
Yes, we can, loud and clear.
Okay, so I heard somebody's. So he was at a board meeting in Otta, Abeokuta, Otta, Ogun State. We are in Lagos. Now, during the board meeting, he slumped, and in that board meeting was one of the doctors. He immediately recognized it was a stroke. Called me. I said, "Well, can you get here on time?" Now, at that time, we didn't have a CT scan. So I said, take the patient straight to St. Nicholas. St. Nicholas has a CT scan. Went straight to St. Nicholas. Our team now went to St. Nicholas, looked at the CT scan with the neurologist and radiologist and agreed this was a candidate for a stroke, thrombolytic therapy. He wasn't able to talk. He was paralyzed on the left side, completely paralyzed on the left side. He got to St. Nicholas within 19 minutes. We got there and were able to give him this drug within 2 hours. He recovered almost completely within a couple of hours. And by the next day, he was almost back to normal. The only problem was he could no longer speak English. But he was able to speak his language, walk about, and able to return to his home country. So just to show you, these things work. It requires a lot of logistics if you're not if you don't visit the hospital immediately, that can take care of you. But if you get to the hospital in time and you make sure you get to the hospital, that can take care of a stroke. Many hospitals cannot. But you get to hospital in time, it is critical to get there within the first 2 to 3 hours. It is very critical. So please, those of you in the audience who are non-medical, if you suspect a stroke, please get there on time. It is critical. Now, what are the risk factors? Like I said, majority of majority of these strokes and heart attacks are preventable. Now, why are we relating strokes to heart attacks? Let me explain that briefly. It is all in the same blood circulation. Now, look at it like plumbing in your house. It's the same pipes that go upstairs, that go downstairs, that go to the middle floor. It's the same pipes. And what happens with a stroke is one of those pipes gets blocked or bursts. This can happen in any of the floors. It's the same pipe that supplies the brain, the same pipe that supplies the heart. So it's the same causes that cause the blockages. So this just shows you where the heart is and where the brain is, and you can see they're all connected by the blood vessels. So what are the non-modifiable risk factors? The ones you can't modify that we can't do anything about, one is age. The older you get, the higher your chances of a stroke. Very few of you have seen strokes in babies, but most of the strokes happen in the older population. Sex. Men tend to have more strokes than women, although after menopause, women catch up with men. Family history. If there's a strong family history, your father, your mother, brother has had a stroke, there's a higher chance that you will have a stroke. And strokes are also more common in African people. And that's for a variety of reasons. Now, what are the risk factors we can control? Number one, in Nigeria and almost all over the world, is high blood pressure. And I can tell you that most of the strokes I see in men, young men, are patients who know they have high blood pressure, but do not take their medications because of sometimes because of the side effects. And the most common side effect patients complain about is ED, erectile dysfunction. Now, what I would like to tell you is, yes, some of these medications can cause ED, but it is important to communicate with your doctor. There are several medications. We can change them around to find one that will not cause trouble for you. But also remember this, the ED you're worried about, once you have a stroke, that part of your life is also gone. So it's important you prevent the stroke in the first place. So keep your blood pressure controlled, take your medicines, and do what your doctor says and have it checked regularly. There are other diseases which are common in Nigeria. Diabetes, quite common, very, very common. And it's a common cause of stroke. Cholesterol, high cholesterol, very common. Didn't used to be common when we were in medical school, but now it is very common, probably because of the food we eat, our lifestyles, and obesity is now a major problem in Nigeria. There is a lot of obesity, and obesity leads to diabetes. It increases your cholesterol. It causes something called metabolic syndrome, and just puts you at risk for a variety of things, including strokes and heart attacks. Now, of course, lifestyle. Smoking. Luckily, fortunately for us in this part of the world, Nigeria, smoking is not a big deal, but there's still enough people who smoke that cause trouble for themselves. Alcohol. This is a tricky topic because it used to be said that alcohol, especially red wine, is protective. of the heart and helps you reduce your chances of a stroke and heart attack. Unfortunately, this is beginning to have been proven wrong. And more recent studies are showing any amount of alcohol is just not good. So those days of saying one glass of wine helps your heart, it turns out that that might not be accurate. And any amount of alcohol is not good. I'm not saying you have to all stop drinking. I'm just saying alcohol should not be regarded as something completely benign or even helpful. Now, of course, diet. We all tend to, most of us know what is bad to eat. But let me say one or two things about diet and some of the things going on the internet about cholesterol not being important. Statins are not important. That it's the drug companies making money from statins. That's why they're saying we should take statins. That is not true. Cholesterol in the body is bad. All right. Now there's different types of cholesterol, but the bad one is the LDL that binds the blood, that binds to the blood vessels and causes narrowing of the blood vessels. Now, cholesterol in the diet itself, this is where the misinformation comes. Cholesterol in the diet itself is not necessarily bad. The places you get cholesterol are eggs, lobster, shrimp, and things like that. We used to say, don't eat the egg yolk, don't eat lobster, don't eat shrimp. But it turns out that type of cholesterol found in those things is not converted to the bad cholesterol when you eat them. But when you have high cholesterol in your blood, it causes trouble and it can lead to heart attack and stroke. So it is important to understand the difference between cholesterol in the food and cholesterol in your blood. What's bad in the food is what we call saturated fats, meat, anything fried chicken, chicken skin, things like that are bad. So please do not misunderstand all that false news going around the internet. Then the next thing is inactivity. Many of us have become sedentary. Drive our car to the doorstep. Do not walk up the stairs. Take the elevator to the first floor. Inactivity is another major cause of these problems, stroke and heart attack. Now, from the heart can sometimes lead to a stroke. There's a very common thing, which I think is the third most common reason for a stroke in Nigeria is atrial fibrillation. Dr. Ben might be able to clarify what number it is, but it's a very common cause of stroke in Nigeria. Now, what is atrial fibrillation? Difficult to say without showing you an animation of it, but atrial fibrillation is essentially an irregular beating of the top part of your heart. So the top part of your heart is beating irregularly and fast. Blood clots tend to form around that part, and then when it pumps properly, that blood clot can move to the brain or any other part of the body. So atrial fibrillation is a common cause. If you have your regular checkups, they will most likely find that you have atrial fibrillation and treat you appropriately. Heart failure, which means weakness of the heart muscle, pump failure. The heart muscle is weak. That is your tank that's designed to pump water up to the fourth floor can only pump water to the first floor. It hasn't stopped, it hasn't failed altogether, but the heart function is weak. Blood clots tend to form in that situation and can move to the brain and cause a stroke. And obviously a prior heart attack. So basically, atherosclerosis is cholesterol buildup in the blood vessels. It causes narrowing and that causes ischemic strokes. Hypertension does the same thing. It damages the brain, it damages the kidneys, it damages the heart. Hypertension is our most common cause of stroke in this country, and we need to take care of it. So basically, know your numbers, blood pressure, sugar, cholesterol, especially if you have high blood pressure. You should take your blood pressure regularly at home and make sure it is under control. Cholesterol, sugar, if you have diabetes, please do not play with the sugar. Make sure your sugar is well controlled. Take your drugs, eat appropriately. Cholesterol, the same thing. If they put you on the statin, please stay on the statin. Only a few people cannot tolerate statins. Statins have cut the amount of heart attacks and strokes by over 50% in the past 10 years. So they're very good drugs and they're safe. As always, eat right, exercise more, and if you smoke, don't smoke. And like I said, please take your medications and follow up with your doctor regularly. So basically, that's what I want to talk about. And Dr. Ahmed will talk to us about what happens if prevention doesn't work. And please try to prevent this event. Do not take things for granted and say, oh, it is not my portion. You'll be surprised how easily it can become your portion. Thank you.
Thank you very, very much, Dr. Johnson. Such a thought-provoking presentation. A lot to learn from the presentation. I can already feel the heat in the house, probably when you mentioned the alcohol aspect. I'm happy you shared so much light on every area concerning lifestyle habits and everything. So there's something for everyone to take back home from this session. You've really given us a lot to reflect on, and we really appreciate your time. We are going to move over now to the next speaker who's going to be taking us on the part 3 of this session. He's going to be talking on I have had a stroke. What are my options? He's going to talk on emergency treatment of strokes. He's going to talk about thrombolytics, clot busters. He's also going to talk about mechanical thrombectomy. He's going to talk about the concept of a stroke center and then stroke unit. So let me introduce Dr. Ahmed Ninalowo to you. He is a US-trained double-boarded diagnostic and vascular/interventional radiologist who completed his training at the prestigious University of Pennsylvania and is the first US-trained physician to offer the full spectrum of interventional radiology services in Nigeria. He obtained his medical degree at the University of Illinois and graduated at the top of his class with honors, Alpha Omega Alpha. He then went on to residency in diagnostic radiology at the University of Maryland Medical Center. He started his practice at Doc Nigeria in 2018 and has since moved his practice primarily to Nigeria to deliver interventional radiology care to Nigeria and sub-Saharan African patients. Dr. Ninalowo has pioneered many procedures in Nigeria and West Africa, including the first transjugular mechanical thrombectomy for stroke, first prostate artery embolization, first endovascular repair of aortic aneurysm, first scrotal varicocele embolization, to name but a few. He is well known and passionate for treatment of uterine fibroids with a minimally invasive procedure called the uterine fibroid embolization. Dr. Ninalowo has been at the forefront of creating sustainability for the field of interventional radiology in Nigeria, with a focus on training physicians primarily from the public sector who can then provide services to low-income patients in these settings. He is the co-founder and CEO of Accurate Radiology, the first Nigerian teleradiology company providing remote teleradiology services to many hospitals in West Africa and market leader in Nigeria. This has allowed brain gain for the Nigerian health sector, as many radiologists who have left Nigeria can now provide teleradiology services in Nigeria to Nigeria patients while abroad. He has a passion for improving access to radiology services and minimally invasive therapies and continues to persevere in the quest to make this readily available to the Nigerian population. I want to say a big welcome to you, Dr. Ninalowo, and you have 8 minutes to make your presentation at this point. Thank you very much.
All right, thank you very much, Otis. Can you hear me clearly?
Very loud and clear, sir. Go ahead.
All right, very good. So I'm going to run through this. So I get to do a bit of the fun part, talk about treatment. So some of the other speakers have talked about the symptoms of a stroke, but I think the biggest thing we can impart on you on this talk is the fact that time is brain, right? Millions of brain cells die every minute when you have a stroke. So it's important to understand the concept that time is brain. When you have stroke symptoms, you need to move fast. So essentially, the mantra of treatment anywhere for stroke is, again, moving fast, because moving fast leads to stroke survival. But the question in Nigeria, given the breakdown in services and the breakdown in healthcare and the breakdown in everything we have in this country, is what can I do today to make sure that I am stroke ready for my family member? Because really what we're doing is making sure that we're ready so that when one of our family members has a stroke, we can do something fast. And the biggest thing you can do today is basically looking for a stroke-capable hospital near you. And what does that mean? When we say stroke-capable hospital, that means a hospital that has staff that's knowledgeable to treat a stroke, a hospital that has a neurologist on site or has a tele-stroke network. And this is some of the services that's provided by one of our partners here at Regions. And then a hospital that has a CT scan on site. And I cannot emphasize enough what the importance of this is, that they have the diagnostic capabilities to basically do a clinical exam on you and then do a CT scan on site and not send you out to a diagnostic center to then come back to that hospital, because again, time is brain, and you need to understand this mantra of time is brain. And basically, if you look at this is the American Heart Association treatment for stroke. And if you see everything on this chart, it's all about time, right? When we have a patient that comes into the hospital with a stroke, we need within 10 minutes of that patient being in the hospital or being in the ER to do all of these evaluations, including doing basically ordering a CT scan of the brain, doing an ECG on the patient, getting a glucose, doing a physical exam. Within 25 minutes of that patient being in that emergency room, a neurologist has to have seen that patient, or somebody from the stroke center has to have seen that patient. And then you're getting that CT scan right away so that you can make decisions on that patient. And why is it so important that that hospital has a CT scan? The reason it's important is because we have to make this distinction. Dr. Ayawu talked about the two different types of stroke earlier. And one is ischemic stroke, where there's a blood clot blocking a vessel and not allowing blood to get to a part of the brain. And the other is hemorrhagic stroke. And this is an example of a CT scan of both an ischemic stroke and a hemorrhagic stroke. In this case, this patient is coming to the hospital with symptoms of a stroke, and we don't see any brightness on the CT scan. We also don't see any darkness. And this is a patient that may be eligible for something called thrombolytic therapy that we will talk about. And this could be life-changing therapy in these situations. If you see something like this on a patient that has a stroke and they have all this whiteness, which means blood within the brain, that means this patient has a hemorrhagic stroke. And when you have a hemorrhagic stroke, the treatment paradigm is completely different than where we go with a ischemic stroke in these situations. So when you have a ischemic stroke, the biggest decision we have to make in those patients is, are you eligible or are you not eligible for something called thrombolytic therapy? And what is thrombolytic therapy? Thrombolytic therapy is essentially putting in a medication into your IV line. And this medication is a very powerful medication. We call it the biggest blockbuster in medicine. And as you see, along with the medication, we have a timer on it. The reason we have a timer on it is that you can only get this medication within a very short period of time, typically about 4 to 4.5 hours from the symptom onset. So it's important that when the family member has a stroke, you start to look at the time. What time were the first symptoms noticed in that family member? If they had a wake-up stroke, what time did they wake up and what time did we notice those symptoms? Because his history is so critically important for us to make decisions in a hospital. Because if a patient has a stroke and it's been more than 4.5 hours, they cannot get these medications, as the risks significantly outweigh the benefits in that situation. So we have this telestroke network here in Lagos on our team. And the telestroke network is headed by the folks at the Regions Hospital in Owerri. And this is what I'm saying, is that we do not need a stroke neurologist that's physically available or physically present in that hospital. But we need somebody that we can call and they will pick up the phone immediately. And what does that mean? It means we're working in a multidisciplinary fashion, meaning a patient comes into the hospital with a stroke, they've activated the neurointensivists who would make decisions on what happens in the stroke. They've also activated our team, who are the vascular neurologists, to make sure that if a patient has something called a large vessel occlusion, we can also take care of that, which I will talk about also. So if a patient is a candidate for thrombolytic therapy, we start to give those patients thrombolytic therapy, and those patients will typically do well in most cases. However, in some cases, patients also could have something called a large vessel occlusion. And what does this mean? This is an example of a CT scan of a patient. This is the right side of the patient. This is the left side of the patient. And as you can see on this patient, this blood vessel continues to go on all the way to the lateral side of the brain, to the side of the brain. In this case, on this right side, the blood vessel just stops immediately. What that means is that there's a blood clot within this blood vessel that's not allowing blood to get to this part of the brain. And as you can imagine, if you do not restore blood flow to that entire of the brain, that is dead tissue. And again, time is brain, you need to move fast. In these situations, when you get that CT angiogram, we start to activate something called the mechanical thrombectomy team, which we are part of. And basically what we're doing is we're going into the artery in the groin of the patient. We're not going into the brain, we're not opening up the head. We're basically going into a very small artery in the groin, We're going up with a catheter all the way into the brain to basically go remove blood clot. In this patient, this is the blood clot that was removed in this patient and was able to restore blood flow back to the brain. And I'll show you an example. This is a 67-year-old male that came in 13 hours after a stroke. As you can see, this is the middle cerebral artery again, completely stopped. This is a large vessel occlusion. We can see that it's completely stopped there. After restoration of blood flow and doing thrombectomy, you could see that we've now restored blood flow to that side of the brain and there's now flow. And this is a video showing you the same thing. You can see that that blood vessel is completely stopped here. And basically when you do the thrombectomy, you can see now that there's now blood flow restored to that side of the brain. And again, this is a life-changing therapy for a patient who was coming with a stroke. Same thing, a 68-year-old male came in to the hospital with a stroke. Dude, we did the CT scan, nothing really to see. We did the CT angiogram. You could see on the CT angiogram that that blood vessel is stopped again. What do? We activate the emergency team to come in. And in those cases, time is brain. We drop everything we're doing and we come in for that patient. And as you can see on this video here, you can see that there's no blood flow to this side of the brain. The blood vessel is completely stopped. After thrombectomy, you can see that the blood flow to that side of the brain is now completely restored. And these are patients that do very well if you could restore that blood flow. And on these patients, we will typically get a CT scan on them about 1 to 2 days later to see how did we do. Did they do well after thrombectomy? And in this case, for example, the place marked in red here is what we expected that patient to lose, right? If we did not do a thrombectomy. However, because we did a thrombectomy on that patient, we were able to save all of this volume of tissue in the brain, and that patient only lost this small amount of tissue, which means he could go back to his normal life without significant disability. This is our stroke team with IR Doc, First Cardiology Consultants, and Regis Healthcare. But again, the important thing here is collaboration to make sure that we can deliver care to patients when they need it. Thank you very much.
Thank you very much, Dr. Ninalowo. Very insightful session with you. We're going to bring back again Professor Ben Anyanwu. He's going to take us on the last part where he's going to be talking about, I have missed the acute treatment window. What options are there for those who have already suffered a stroke? He's going to talk about multidisciplinary approach to stroke treatment, secondary stroke prevention, and also neuro rehabilitation. So over to you, Dr. Ben. Are you there, Dr. Ben?
Yes. Can you hear me now?
Very loud and clear. Go ahead.
Okay. Thank you for having me back, and many thanks to my collaborators who are not just collaborators in this presentation, but also collaborators in stroke care and management in Nigeria, mainly in the private sector, obviously, as we could see. So for the next few minutes, I'm going to be addressing some critical aspects of what to do after you have missed that window that Dr. Ninalowo just talked about. So I'll start by asking that question for everybody. Have missed the acute stroke treatment. What are my options? Basically here we're talking about people who could not qualify for that clot buster Dr. Ninalowo talked about, or the thrombectomy, which is available, by the way, in some select hospitals across the country. So before I address this, let me be clear for us to know that most people who suffer a stroke die because of the secondary complications. The stroke does not kill a lot of people who have suffered a stroke. They die because of the secondary complications, which is things that can happen to you just because you have just suffered a stroke. Number one on top of that list is the infections. A lot of them die because they are not able to swallow very well. They develop what we call aspiration pneumonia. And from that, they develop sepsis, and then they can die from it. They die also from urinary tract infections, being top on the list as well. A lot of people die from immobility-related issues, things like pressure sores, deep venous thrombosis, which occur because of blood clots in the deep veins, usually of the legs, that now travel to the lungs and cause what we call pulmonary embolism. When that happens, the patient can literally stop supplying oxygen to their parts of the body and die almost in minutes. People die as well because of seizures and anxiety, as well as depression. I would tell you that it's estimated that about 10 to 20% of patients who suffer from stroke in the United States suffer ultimately depression. But I'll tell you that in our country, this number is much, much, much higher. I don't know if there are any data out there that has looked at this, but this is also commoner in men. The reason why this happens, as you can imagine, is because stroke, interestingly, even in Nigeria, tends to occur in younger age group, usually people about 40 to 50s to early 60s, than in developed world, where stroke mainly occur in people who are much, much older. Sadly, most of these people within this age group are the breadwinners for their family and also represent the most economically viable people, even in our nation and our economy. So, how can you solve? What do you do if you've had a stroke and you didn't qualify for treatment? And again, I'm talking about people who have had a stroke probably within the last 1 month, 2 months, 6 months, even years sometimes. One of the things that can restore function in these patients is called neurorehabilitation. And by neurorehabilitation, we're saying that we're rehabilitating those nerves and neurons and muscles that have gotten weak as a result of the stroke. So what is neurorehabilitation and what does it encompass? It encompasses physical therapy, what is generally known in the country as physiotherapy. But it's important to understand that physiotherapy requires the right instruments and the right trained personnel to be able to be effective, and not the regular massage that people come to your home and say they're doing massage on you. Therefore, my recommendation to my patients always is that if you've suffered a stroke, go to a place that understands stroke rehabilitation, that would offer you the chance of recovering, even though you may not have received that thrombectomy or the thrombolytics, the clot buster. Occupational therapy. Occupational therapy helps to teach people how to care for themselves, basically going back to what they can do in their activity daily living. For instance, dressing themselves, cooking, ability to change themselves, ability to breathe themselves, ability to write, ability to read. Key is to get the person back to what they used to be before the stroke occurred. In a lot of cases, the patient may not be able to recover completely, but with good occupational therapy matched with physical therapy, they can return very close to what they used to be, or sometimes recover completely and go back to the regular life. Some patients with stroke can also have speech difficulties, and speech difficulty can be restored using what we call speech therapy. So these three aspects of therapy encompass what is regarded as neurorehabilitation, together with a fourth one, which is cognitive therapy, to help the person read, write, and think, as well as perform optimally in their cognitive performance on a daily basis. So if you've had a stroke and you're looking to recover, I will always recommend that you go to a place that can offer you complete set of neurorehabilitation, not just physical therapy, but also occupational therapy, speech therapy if you have problems speaking or understanding, as well as cognitive therapy, and sometimes psychotherapy because of the high incidence of depression associated with stroke in our environment. However, like my colleague said, stroke care requires a multidisciplinary team. This is very important. And I've seen somebody ask, so where should I go if I've had a stroke? If you've had a stroke, it's important that you go to a stroke-ready hospital. In this case, I'm referring to where you have the components to take care of the patient in a multidisciplinary fashion. It's not just the job of the cardiologist or the neurologist or the interventionist. It is a job of all hands coming together to take care of you. But these are people who are also vested in the management of stroke. It requires that you have the relevant doctors, the relevant stroke-trained nurses, and more importantly, also ability to intervene or give some of these drugs that we talked about. It also requires that some of this, the hospital has what is called a stroke unit. And within a stroke unit, the difference is that you have all this multidisciplinary team working together rather than the regular ward that you put patients. So this is really the component I just talked about. The doctor, which comprises specialists of different areas, particularly the neurologist trained in stroke, the cardiologist, the interventionist, as you've just heard, and sometimes other doctors as well that can come together to take care of your problem, depending on what is going on. The stroke nurse, the pharmacist, the neuropsychologist, the physiotherapist, the occupational therapy, the speech therapist, the dietitians, and even the medical social worker where relevant. So it is without argument to say that as part of treating you for stroke, all these people are also coming together to figure out what have caused the stroke and figure out ways to help you not to have a stroke again. Because it is generally known that if you've had a stroke, your chances of having another one is relatively much higher than those who have never suffered a stroke before. This is actually much higher within the first 90 days of having that first stroke and continues to remain very high even up to 5 years and 10 years down the line. Other risk factors, like my colleague talked about, will be family history. So if you've had a family history of stroke and you suffer a stroke, the chances is also much, much higher. And this multidisciplinary team come together not just to treat you in that acute period, but also to figure out what may have caused the stroke and put you on the right medication so that you don't suffer a stroke again. Having that multidisciplinary team is the reason why, as you can hear, Dr. Nilowo said, we have come together as a group of doctors interested in stroke care in the private sector in Nigeria. The Region Stroke Center, through its Stroke Alert program that can really deliver stroke advice and stroke intervention anywhere around the country without being physically there. The FCC Healthcare located in Ikoyi, and of course, the Lagos Center for Endovascular Neurosurgery, that is really the IR doc that Dr. Nilowo talked about, that can intervene on stroke patients 24/7. We're very confident in the things we do, and we follow evidence-based guidelines to help patients who have suffered stroke who decide to come to us. This is how we offer the telemedicine program. The telemedicine program for stroke, like I said, is available 24/7. The doctor doesn't have to be there physically to be able to provide that advice. We cover both telestroke, teleneurology, and other aspects of neurological recovery or advice for patients who have had a stroke. So I will summarize by saying stroke recovery starts with choosing the right hospital or choosing the right group. Because once you make the mistake of not going to the right place, then the rest can become very difficult for you to reverse as you go along. This is, again, our group of doctors who have come together to form this consortium. Dr. Adeyemi Johnson, who you have heard from, Dr. Hamid Nilowo, who you have also heard from, and my humble self. With this, I thank you guys for spending time with us and listening to us, and we can take more questions. Thank you.
Thank you very much, Prof. Very insightful. You've actually touched on every area that stands as a concern for everyone present here. Now, this is the opportunity for anyone who has questions to freely ask your questions, suggestions, comments. Very orderly. So if you have questions, you can just indicate by raising up your hands, and then would open the floor to you to ask your questions. So while we wait for any indication from anyone, there's some questions that have already been asked on the chat section. Yeah, we have an Okoli Chidera that wants to ask a question. So let's take her first. You can unmute and ask your question. Go ahead, Chidima, sorry, I'm trying to get the name here. Chidima Okongwu. Go ahead and ask a question. Just unmute and ask your question, please.
Okay, thank you very much, Dr. Ike. It's actually a he, not a she.
Oh, apologies. Go ahead. Okay, what about Okoli Chidera?
Yes.
Yes,
so my first question goes to Dr. Adeyemi Johnson, because he mentioned using statins to control cholesterol for most patients. But my experience in the primary care setting is that most patients, especially 70% of those patients, stop taking those drugs because of the side effects of muscle pain. So even when you try to counsel them, so at that point, what do you really do for them? Considering the statin therapy to reduce the cholesterol levels. And also, if we're talking about CT scan. So considering the fact that most of us, or not most of us anyway, Nigeria is a resource limited setting. So if you're maybe where you're working, there's no available CT scan within the next 30 minutes, what do you do? Is there any way you can rely on clinical examinations to maybe differentiate between an ischemic stroke and a hemorrhagic stroke? That's my second question. That one goes to Dr. Anyang.
Okay,
so
can you hear me?
my two
I'm not
questions.
sure whose
And how
internet
do
is
we
bad. Okay,
Hello?
as far as statins go,
Hello?
Yes, we're with you. Dr. Johnson, we can't hear you anymore.
I don't know who's cut off, me or...
Okay, go ahead. We can hear you now, Dr. Johnson.
Okay, I'm trapped in Abuja, and I tell you, Abuja's internet connectivity is a different story. Anyway, as far as statins go, I can give you my own example. Many years ago, my cholesterol was high when I was in my 40s. My doctors then put me on 10 milligrams of atorvastatin, Lipitor, 10, just 10. I complained that it caused muscle aches, it caused back pain, it caused ED. There's nothing I didn't say, memory loss. So I stopped taking it. Anyway, when I was 50, I almost got a heart attack. Almost. Luckily, I got a stent placed before the heart attack came. So I like to use my own example many times with my patients. If I wasn't a cardiologist and if I didn't have access to a cath lab where I was working, I would have had a heart attack. And all because I decided to believe I had all the side effects. So after the heart attack, I went from 10 of statins, of Lipitor, to 80, plus another drug. I don't know if you guys are hearing me because my screen seems to have frozen.
Yes, we can hear you, Dr. Johnson.
Yes,
Go ahead.
Okay. So I use myself as an example of what happens if you don't take statin drugs. Okay. And I can tell you, my experience is not 70% go get muscle aches. Mine is more like 20% I see. And I counsel them and I say, okay, let's reduce the dose. Take it every other day. A little bit of statin is better than none. Then I add ezetimibe, which doesn't tend to have the same side effects to the statin, or use ezetimibe on its own. Ezetimibe is not as strong, but it's inexpensive. But I do everything I can to encourage them, give them my own life example, and tell them to try. Do every other day. Mine gives me muscle aches, it still does. So weekends, I tend to stop it because the rest of the week I feel quite bad. So, but I think to myself, heart attack, stroke, muscle ache. I choose the muscle ache very quietly. But yes, statins do cause muscle aches. People who don't take statins don't believe that they do. But I can tell you from my experience, yes, it do cause muscle aches. So I reduce the dose, try it every other day, do something like that, ask them to take CoQ10. As far as clinically being able to recognize ischemic stroke from hemorrhagic stroke, I think I leave that to Dr. Ben to discuss.
Okay. Thank you very much, sir.
Sure.
Yeah, okay, Dr. Ben, you might want to take over the other part of the question he asked.
Sure.
Yeah.
So it's interesting that I keep hearing this question and this request over and over. I've heard it even in the United States, in Nigeria, in a lot of conferences, and people talk about it. How can you? And some people actually say you can distinguish between hemorrhagic stroke and ischemic stroke by clinical examination. Let me say this again and again. No, you cannot. You absolutely cannot distinguish between hemorrhagic stroke and ischemic stroke based on your bedside clinical examination. And I remember, I no longer hear this a lot in Nigeria. When I first came back, one of the things that recurring things people would say, they would say, oh, the patient doesn't have the money to do the CT scan, or we don't have CT scan. But within the last 70 years, a lot of things have changed. And I remember I used to tell people, if your patient has 30,000 naira to spend, this was when CT was much cheaper, please make your patient spend that money to do that CT scan to distinguish between that hemorrhagic stroke and ischemic stroke. Luckily, over time, CT scan is almost in every 30 minutes away from wherever you live now. Please get that CT scan on your patient because everything changes the moment you recognize that it's a hemorrhagic stroke, a bleeding stroke, versus an ischemic stroke, which is a non-bleeding stroke. You put your patient at a great risk without understanding the type of stroke they have had, because the pathway for managing those types of strokes is very different. For instance, in one of them, you can quickly give them blood thinners. In the other, you want to avoid blood thinners because it can make things worse. In one of them, you can reduce the blood pressure down to reduce the chances of the hemorrhage getting worse. In the other, you want that blood pressure to be on, if possible, on a high side. And if you reduce that blood pressure drastically down, the stroke can become worse. In one of them, you can put them on blood thinners for DVT prophylaxis early enough. In the other one, you cannot. So the care of these patients are very different, and it's very important and vital that you're able to diagnose and make for certain and know for certain the type of stroke your patient has had. This will be my submission on this.
Thank you very much, Dr. Ben. Quite straight to the point. We have another hand raised. Adeleke Sheung, you can unmute and ask a question very quickly. Thank you.
Sorry, I've not asked my question. Chidinma Okongu.
Okay, let's take Adeleke Sheung first, then I'll come to you. So sorry, apologies.
Okay, sir. Yes, sir. Yes, sir. At a point, I was lost during the seminar. So I wanted to ask a question, sir. I did my lipid profile of recent, which my good cholesterol was low, which I think it was 37. So I don't know if that is okay, or is there any drug I can take to probably boost it to the normal level? And my second question is this, sir, because I've been on BP drug for some months now. And of recent, since last week, I started noticing that my pulse rate has been reducing from 48 to 51. So it has been within that range since last week. So I don't know if this is also normal for that, sir. Thank you, sir. Those are my questions.
Okay, I think that question is probably for me. I didn't get the second question. You said something went from 48 to 51. What was that?
Yes, my pulse rate. My pulse rate.
Oh, pulse rate. Oh, okay. I had
Yes.
prostate and I couldn't understand. Okay.
Pulse.
Yes. Okay. The second question, I'm not aware of statins, causing any decrease in pulse rate. I'm not aware. It might just be you have started exercising and getting fitter and your heart rate went down accordingly, but I don't think it's due to the statins. But the difference is not much. 51-48 is all about the same when you take the average. Now, as far as HDL, that's a very good, important question. It is thought that a high HDL is protective. However, all the drugs that have been shown to increase HDL, at least in human beings so far, have not shown any improvement in reducing the chances of a stroke or heart attack. In fact, in some cases, they seem to have made things worse. So yes, high HDL is supposed to be protective, but so far, the drugs used to raise the HDL have not been very helpful. So that's one reason why we don't treat low HDL with drugs. Now, the physiologic way of getting your HDL up is one, eating more fish, two is exercising, and three, if you smoke, stop smoking. Those are the ways and yes, I said exercise. And those are the ways we naturally get HDL up. But generally, the things we do to make HDL go up also bring down your LDL, which is the key thing. Now, LDL is what we look at the most because that's what has been demonstrated by several studies, that lowering your LDL significantly reduces your chances of a stroke or heart attack. And contrary to what we used to believe many years ago, there is no such thing as your LDL being too low. For people who have had a stroke or heart attack in the past or recently, the new recommendation is as low as possible. And the people who go below 55 milligrams tend to have less strokes than those under 100 and under 120. So for what we call secondary prevention, that is those who have suffered a heart attack or stroke in the past, the target range for bad cholesterol, which is LDL, is quite low. So, but as far as raising HDL, the drugs that do so have not been shown to have any benefit.
Okay, thank you very much, Dr. Johnson. We have some other hands raised. I don't know if the person that wanted to ask a question, I see your hands has been brought down. Possibly your question has been addressed indirectly. I don't know.
No, I'm still here. Sorry, I didn't know I've taken it down. Good afternoon, everybody. Can we hear me?
Good afternoon. Yes, please. We can hear you.
My question is to Professor Anyanwu. Is there seeing that one from the class, or sorry, from the webinar, 1 in every 4, that's 25% of the average population will have a stroke. Does Region Stroke Center have a curriculum where they train interested physicians in stroke rehabilitation? Because I can say for sure that since we have a stroke unit / a critical care unit in my hospital, it's opened my eyes to how many patients actually come down with stroke and how many patients are in the hospital with stroke. So is there a program in Region Strokes where physicians who are interested in stroke rehabilitation, seeing that most people will come after this golden period for acute stroke reversal, and most will have to depend on the secondary care and rehabilitation. Is there a structured program to make more physicians involved in stroke neurorehabilitation? Thank you.
Yeah, thank you. Very good question. Let me just first tell you that part of the commitment of our consortium, meaning the three of us, is that we provide education, we support trainees, and we try to spread what we can do to other centers, if possible, and other physicians. The reason why we do that is that we know we can't treat everybody. So just to answer you that specific question about Regions Stroke Center, yes, we can accept doctors who are interested to gain more knowledge on stroke care, especially the rehabilitation aspect of it. The person just has to apply through our email, HR email, and then we'll speak to the person, and then we can arrange that externship for the person. Just for the sake of time and just for you to remember, it's probably better for you to call the number on the screen, which is 0704 7000013, which is our client relations manager, who can take up on that and help you navigate the way to apply for that. Yes, we can.
Okay, thank you very much, Dr. Ben. We have posted the contact information of First Cardiology Consultants, also done the same for IR Doc and also Regions Specialist Hospitals. In the chat box, you can go there and scroll. If you want to contact First Cardiology, you just go ahead with the contact information, or any other of the facilities that are hosting this joint webinar. We have more hands raised, but we're trying also to manage time. It would help if we have some of these questions posted on the chat box so that the speakers can just directly answer you while in the chat. Also, I also want to urge the speakers, if you can go through the chat box, there are some questions there. You are able to just respond to them, so we're able to see as many as we can attend to. I'm going to let Donald Okerulu, your hand is raised. You can unmute and ask your question now. Thank you.
Good afternoon, good evening, Prof. Good evening, everyone. My question goes to Prof. Benjamin. Please, I want him to highlight on the use of aspirin in acute stroke, whether it's still obtainable now. That's my question. Thank you very much.
Okay, your audio was very low. I don't know if Prof got that question.
Well, I think if the question was directed to me, I think I did get that. Now, we can't treat or discuss everything that has to do with stroke care in a 1-hour webinar. And therefore, we chose carefully what to talk about that will benefit most people. But just to answer that specific question, yes, there is a role of aspirin, especially in ischemic stroke, even in hemorrhagic stroke at some point, for secondary stroke prevention. There are specific guidelines for the dose of the aspirin within the first 2 weeks and then subsequently. There are also some rules for dual antiplatelet therapy, which basically is aspirin and clopidogrel. Those rules are very limited based on specific trials that demonstrated its benefit in patients with less disabling strokes. But again, we didn't have to address everything in this short presentation. Hopefully, based on the number of people who have attended this webinar, we can probably do more webinars as a group and educate more people, and probably have sessions that will have to answer those specific questions.
Okay. Thank you very much, Dr. Ben. So for those, we have a lot of questions on the chat. What you can do is you can actually mail most of those questions to us, and we'll direct these questions to each of the respective speakers. I'll get the answers from them and respond to the mail. For purpose of time, we're going to take just 3 more questions. We have a lot of hands raised up. Just 3 more so that we can wrap up for this webinar. Nika Ane, if you can unmute and ask your question very quickly.
Okay, thank you very much. Good afternoon, Dr. Good afternoon, everyone. So my question goes like this. My mom, she suffered stroke. She suffered stroke, and then she was in the village, so she couldn't get the initial thrombolytic care. So when she came back to Lagos, that we had to now put her through the neuro rehabilitation. So, but prior to that, she had osteoporosis, so she couldn't walk very well. So her cognitive is fine. She can talk, she can think, but in terms of physically being able to walk again, so like one leg is bigger than the other one. So in this situation, how do we go about it, and what's the possible solution or care that she can get? Thank you.
So again, let me take that very quickly. So you said neurorehabilitation. I'm not going to ask you where they got it, but where your mother was getting that. But I did expand a little bit on what constitutes neurorehabilitation, to be sure that she actually is getting that physical therapy in an organized setting with protocols, and also that occupational therapy with trained people who are organized and follow evidence-based guidelines to help these patients. Having said that, there are some few stroke patients that may not recover depending on when you begin therapy, and depending on where what part of the stroke brain that the stroke affected. My recommendation would be for you to go to a neurologist who is going to reevaluate her and be able to tell you a little bit more whether she can be rehabilitated or not. In the most part, most patients who have suffered a stroke can be rehabilitated. They may not be able to go back to what they were doing before, but they can live an independent life and be part of this family unit. But this is also even more possible if they got early intervention. And that's the reason why we emphasize this early intervention, as you heard from Dr. Hamid in the lower, that's important, because it takes the edge out of you if you get that thrombolytics, which is available in the centers we represent, both in Lagos and over here, and probably other centers, of course, and also that mechanical thrombectomy, pulling out of that clot and restoring blood flow to that part of the brain to restore function.
Thank you very much, Dr. Ben. Two more questions to go. Catherine Ajay, you might want to unmute and ask a question very quickly.
Good evening, everybody. My question is this. I don't know who to try to, if I should say Dr. Now or Dr. Ninalo, but then my question is this. Let's assume, I know the reason why maybe we'll say CT scan most of the time because it's cost effective. But in a situation whereby a facility has both MRI and CT scan, which of these will give you more detailed information that you want to go for if the patient has the money for any one of them?
Primary,
to answer that.
Yeah, so the primary evaluation modality for stroke in the acute setting is CT scan. The reason is that a CT scan can take less than 5 minutes to do. And you can also get a lot of information, such as looking for bleed or no bleed on a CT scan. An MRI takes much longer to do, and it's harder to get on an MRI scanner, which is why CT scanner is the primary modality. In some situations, however, where we don't see anything on the CT scan and we want to answer specific questions, we may then get an MRI on that patient to see if there is an acute stroke. Because what we know about MRI is that MRI can show a stroke within a very, very short period of time, while CT doesn't show a stroke until hours and hours later, right? But really, the critical information for us when we're trying to make decisions in this acute setting is, does the patient have symptoms that are compatible with a stroke? And does the CT scan show blood or no blood? Or does the CT scan show a large volume of infarction? And a CT scan can answer all of those questions.
Okay, thank you very much, Dr. Nina Lowo. One last question. John Dottin, you might want to unmute and ask a question.
Hi, thank you, Dr. Ben, and thank you for the most wonderful webinar. It's been so informative. I just want to find out if there has been any breakthrough with any new pain medication, post-stroke pain medication, or something that can be, new on the market that can be recommended, or where I could get access to that information.
I think I can take that. There are always new medications in the market. However, pain control in patients who have had a stroke requires specialists who are specialized in pain management, being the fact that I've not really seen any post stroke neuropathy or pain that has not been able to be controlled. There are several modalities to do that, both in terms of medications you can take or combination of medications you can take, although that it can be quite challenging to treat, and hence the reason why you need people who are specialized in that.
Yes.
There are also nerve blocks that you can do to be able to help the patients. But in general, I would recommend that you or whoever is having post-stroke pain should go to somebody who specializes in this. Most trained stroke doctors should be able to do this because that's part of our training, to be able to take care of that syndrome, because it's actually quite common in patients who have strokes in certain parts of the brain, particularly the thalamus.
I understand. Oh, thank you very, very much.
Thank you.
Thank you.
Okay. Thank you, everyone. I think for now, we have, if we decide to go through all the numerous questions coming in right now, I'm very sure we're not going to be living here today. So it's only right for us to, draw the curtain. And if you have questions that or concerns you want to raise or suggestions, you're very free to reply the email that sent you the link. So just a moment. You're very free to send a mail to us, and we're going to get the response from each of the respective speaker that your questions is consigning to. So it's a wrap up, and I'd like to thank our three speakers, Dr. Adeyemi Johnson, Professor Ben Ayawu, Dr. Hamed Ninalowo, for your time, your knowledge, and passion. The passion is most important to me. Getting these three great personalities in one place with their very busy schedule, I must say it's a very big one for us. So it's passion, actually. So the passion in helping everyone understand stroke recovery from your different and multiple perspectives. A big thank you to also our organizing team, everyone who's put hands together to make this happen today. We want to appreciate IR Doc that is represented here by Dr. Ninalowo, also Regions Multi-Specialist Facility represented by Professor Ben Ayawu. We want to say a big thank you, and we appreciate this collaborative effort in making this happen. Let us remember that stroke diagnosis is not the end. It's just a call to action for both patients and caregivers to seek the right care, embrace rehabilitation, and stay hopeful. Every minute counts is the theme of this year's World Stroke Day, and it's something that we also should understand that time is of the essence when it comes to stroke. So together we can all build more awareness, build a better support system for our stroke survivors. So once again, I want to say a big thank you to everyone for being part of this conversation. My name is Otis Eyike, and I am the Business Development Manager for First Cardiology Consultant, and also the moderator for this session. It's been a pleasure moderating today's webinar. I want to say have a wonderful day. Keep spreading the message. Stroke is not a death sentence. It is treatable, and recovery is possible. Thank you very much, and have a great evening, everyone.